So this is a new valve. Now, the procedure takes, my first one, what, took an hour and a half? Yeah. Usually the first one takes about 2.5 hours. My first one took an hour and a half. Then the second one, maybe an hour and 15 minutes. Now it's in the 45-minute range. The fastest one was 33 minutes. These are little, see those little things right there? They're little fasteners, like little clips. They're corrosive fuse fasteners. Now, initially, we were putting in about 14 fasteners, but this technology is really taken off. This thing is really helping a lot of people. So I'm taking an advanced course in Denver in a couple of months. And what we're learning there is to put a lot more fasteners and get a longer valve. Overstay night. This is not outpatient. Okay, not outpatient. This is with a general anesthetic. This is surgery. Only surgeons are doing this, not gastroenterologists. The endoscopies, which I do too, because I do everything that gastroenterologists do, so I do as many scopes as they do every single year. Okay, but I'm a surgeon. So the endoscopies are done in endo, well, you know, with sedation, with the medicine that kind of makes you forget things. Okay, this is in the operating suite with an anesthesiologist or a CRNA under a general anesthetic. Okay. Now, right now, one night stay. Nobody can go home the same day. Out of 10, I've done 10. 8 have gone home the next day. 2 stayed 2 nights. Post-op discomfort, minimal. What the patients have told us is their throat right here is kind of sore. Okay, because this thing, the reason that we need the anesthesiologist to have anybody who's had major surgery with a general anesthetic has a tube in their trachea. Okay, it's called intubation, and 99% of the time we go through the mouth. But if say an oral surgeon is excising a tongue cancer or somebody's doing a palate surgery, well, he's operating on the mouth. He can't have any tube in his way. So those patients need nasotracheal intubation, where the tube goes through the nose. Obviously, y'all are asleep, you got gas already, you don't feel it, okay? But the tube goes through the nose into the trachea. So ultimately, it goes into the same pipe, but it goes in through a different manner. So that way, the mouth, I have total access to the mouth to do what I got to do, because the thing's pretty fat, okay? So now, however, the soreness goes away, the throat soreness goes away in less than 48 hours, and that's basically it. I mean, patients, when they've come back to my office, say that they have no pain at all, you know, because there are no cuts. Mm-hmm.
The fasteners, how long are they good for? A lifetime or so many years?
Well, that's a good question. This is what happens. Okay, understand in surgery, okay, whenever we put things together, say you even cut your hand and you're going to get stitches to put your skin back together. Well, all we're doing, and all we've done for thousands of years, is put the tissue together so you scar, right? So you form collagen, you bridge the gap, and you can heal. Because if the gap's too far, then the skin's not going to come together. So when we're inside doing appendectomies and gallbladders and hysterectomies, the stitches or the staples that we use bring the tissue together just so it scars together, okay? So these are polypropylene, plastic, okay? And proline's been around for decades. So we've used it for mesh, you know, for inguinal hernias, ventral hernias. Most people today who have inguinal hernias repaired, there's a piece of proline mesh, a piece of plastic. Now, when we bring the tissue together, so this is the inside right here, but relatively speaking, this is outside the stomach, that little line right there. So the fasteners come together, the tissues are opposed, and then they scar. Okay? Now, but this is I'm glad you asked that question. After this procedure, patients have to be on liquids for 2 weeks. So when patients come to the office, we give them instructions. There's a diet guide, and you know, there's pamphlets that we give that explain everything. But if somebody has this procedure done, and the next day they go eat Whataburger, they're going to pop all the fasteners off. You'll pass them in your poop, you know, it's not going to hurt anything, but you lost your valve and you wasted everybody's time. So when in intestinal surgery, usually when I connect bowel, we use titanium staples. It's metal. Just like the orthopedic surgeons use titanium for the hips and the knees. It's a metal that is accepted by the body. This is not titanium. This is proline, okay? So, to answer your question, if you pass them, because you may, because the body does pass things, rejects things with time. So if you pass them long term, everything's fused with scar already, okay? Or it's just going to stay within the scar and that's the end of that, okay? But ultimately, if you pass these, your valve is already fused. So that's why it's so important, the physical activity. Patients cannot lift more than 5 pounds for 2 weeks after this procedure. Basically, soups, Jell-O, pudding, Ensure. We're talking about stuff like that for the first 2 weeks because we want this valve to really heal and really scar in. And there's a food guide that we give in the office. It's a chart. It's one of the pamphlets. It's on one of the pamphlets. But anyway, the food guide is in the back, and it goes weeks 1 through 12. By week 8, patients are eating everything, whatever they want, okay? Even irritants, whatever they want, because it's all going to stay down. But the first 2 weeks, you know, it's liquids. It's nothing but liquids. And weeks 3 through 7, it's a lot better, though. It's casseroles. You can go to Olive Garden and have spaghetti. So it's food after that. But steaks, enchiladas, not till like week 8. Now, on the first year, because understand this technology has only been around 2 years in the world. So it's still pretty new. That is brand new to El Paso. So already over 5,000 have been performed in the world. On the first year after this procedure was done, most of them initially were done in Europe. 85% of patients are off daily Nexium, omeprazole, you know, the PPIs. They were off completely. Now, hiatal hernia reduction. A lot of these patients have a hiatal hernia. So we can actually reduce the hiatal hernia because with the instrument, we can push the hiatal hernia down and at least 2 centimeters of it can be closed with this procedure. Esophagitis. We're starting to see now Barrett's esophagitis. Barrett's is severe esophagitis that is turning into cancer. So it's what we call dysplasia. It's like when women get a pap smear. The gynecologists are looking for dysplasia of the cervix for cervical cancer. Well, this resolves it. And I think I think this number and this number as the time goes on are going to go up. Now, 2 years now. So this is where we're currently at. 80%. Okay, so 80% of patients are off these meds. Yeah, please, like completely off these meds. Thanks. No, most of the patients are satisfied. Now, the gas, bloat, and the difficulty swallowing, that's with the old procedure, with the Nissen funduplication. Now, you saw that slide with the open and the laparoscopic thing. What we do there, though, it's kind of, it's too much. It's overkill. What happens there, the top of the stomach, the fat part, top of the stomach is called a fundus. And what we do is we twist it on itself, suture it like that, and it stays like that permanently. So if this is the esophagus, we get this piece of stomach and wrap it around like that, literally twist it. And so that creates a bola. That's not very scientific, huh? But a bola, so it doesn't go through the hole, right? So the hole in the diaphragm is called the esophageal hiatus. So that's why it's called a hiatal hernia, Okay, so if you can picture this diaphragm is this big muscle in the middle of our body that separates the chest from the abdomen. It's our breathing muscle, right? So it has to have a hole in it for the esophagus to go through. And so in the old days, and even currently, you know, when we do this laparoscopically, we make a big ball out of the stomach so it doesn't go up anymore. So for the first year, the patients, they feel good. I mean, you know, it works for reflux. It stops their reflux. But after a year, when the patients come back, 2 years later, 3 years later, most of them regret it. So it got to the point where I even stopped doing that surgery. I started referring them out because patients couldn't burp. They have trouble swallowing. God forbid they ever had a beer. They get all bloated because the twist up here does not allow things, because understand, you know, when we drink water or eat food, we displace air, so burping is a natural thing. So people don't have this with the transoral incisionless fundoplication. Up to 80% of patients after this procedure can eat spicy foods, and they'll keep it down. And they don't have to take medicine to counteract it. Now, let me see on the, okay. Now, so the difference, another fundamental difference between this procedure and the old procedure is we're doing it through the stomach. With the other procedure, which once again I've done also, but God forbid you hit the liver, you lacerate the spleen, you hit the pancreas. There's a lot of important things right here, okay? So when you're putting in the tubes, you know, things can happen. On this procedure, the gastric wall is in the way. You can't hit the other organs. You're doing it within the stomach,